This is Black Mental Health Matters. I'm Dr. Kerry-Ann Williams. I'm a psychiatrist practicing in Massachusetts. And this is a podcast that's about everything related to mental wellness in the Black community and beyond. And today, I'm going to be talking about mental health services for immigrants to the US, particularly in Asian, Latinx, African, and Caribbean populations. So with me today to discuss this topic are graduate students from William James College. So I'm going to add them to the podcast now. So we have Jody-Ann Hansen, Tina Wang, and Jackie Pack. Welcome to the podcast. So what we're going to do is start off with some introductions. So I'm going to have Jody-Ann introduce herself first.
Hi, good morning. My name is Jody-Ann Hansen. I am in the clinical mental health counseling program at William James, and my concentration is in African Caribbean mental health counseling with children and families.
All right, and Tina Wang.
Hello, everyone. Good morning. My name is Tina Wang. I am currently a third-year student in the PsyD doctoral program of William James College, and my concentration is Asian mental health.
Thank you. And Jackie Pack.
Hello, everyone. Good morning. I'm Jackie Pack. I'm currently a second-year student in the clinical PsyD program at William James, and I'm concentrating in Latinx mental health.
All right, thank you. So I know you guys have been doing some research in the area of mental health services for immigrants to the US. And, I think about it, and I think for some people that may be listening, they may think, well, isn't it simple? I mean, if you need mental health services, you go to your PCP, get a referral, you go to a clinic, maybe there's a wait list, maybe there isn't, boom, you get mental health services. Why would we be thinking about mental health services specifically for immigrant populations? Are there different considerations that we should be thinking about?
I mean, I definitely feel that there are tons of different considerations when it comes to thinking about immigrants. There are certain communities that don't even know that they have a mental health disorder. There are some individuals who don't know that there is access, and there are certain times when immigrant individuals might not even have a primary care doctor, or they might be afraid to talk to their primary care doctor about what they're going through because of whatever stigma their culture might actually have on the larger community. So there's tons of different things.
Okay, interesting. So there may be a lack of knowledge of the systems. If somebody's just moved to the US, there may be a lack of general access to healthcare in general, not just mental health, but just healthcare in general. And sometimes just that fear of talking about it, not knowing how to talk about it, not being sure what's going to happen if people talk about it. So I guess it sounds like you're alluding to kind of two different kinds of barriers. There's the practical barriers, and then there's kind of more psychological and cultural barriers. Can we talk a little bit more about what some of the practical barriers are for immigrants to the US accessing mental health services based on what you guys have found?
So one thing that I found I'm sure this is kind of across boards in a lot of cultures, but for immigrants of the Latinx descent, they often are working multiple jobs just to support their own family. So it doesn't leave a lot of time. The priority of their mental health or even their physical health isn't at the top of the list because they're trying to support their family to put food on the table, to make sure they're being able to pay utilities, to be paying rent, all that time. And then a lot of times if they're undocumented, they don't even have access to the health insurance. So they're not able to get the mental health help they need. So there's a lot of barriers that go into play, and I think it's a multifaceted problem.
Mm-hmm. Mm-hmm. Yeah. So some of it may have to do with trying to make ends meet financially. So that leaves lack of time because then people are working more than one job. The kind of jobs that people are working don't really lend themselves to taking time off in the middle of the day for an appointment. You also mentioned that sometimes if somebody is doesn't have the paperwork, that they may not actually be able to access at all, or be maybe not comfortable with presenting for services, not sure what's going to happen if somebody finds out. Yeah. Any other practical barriers that people want to talk about?
I mean, you also have to look at the stigma from the original culture when it comes to mental health as well. I know for myself, coming from Jamaica and being a Jamaican immigrant, that we don't necessarily take mental health that well. We don't usually get a lot of access to those kind of services. And whenever we do have any issues like that, it's usually taken care of within the home, because it is something that is considered embarrassing towards the family, and it's not something that you would want to outwardly express, so there is a lot of shame that could be associated with it from the cultural perspective that could actually prevent you from reaching out, to get services here in America.
Right. No, that's absolutely true. I mean, do you guys do you feel like folks from other cultures, do they think about mental health in the same way that we might in North America? Are there differences with how people even think about the concept of mental health?
I guess like I wouldn't have the chance to cover the whole general community of Asia, in a sense due to like its size and the 50 different types of culture it's presenting there. I know from my personal experience growing up as a Chinese American specifically, we have terms that covers psychology in the ways that's basically saying someone is crazy. So the way that you describe crazy person, the same type of characters are used in describing mental health. So what I have experienced working with Chinese immigrants specifically is that I will have to do a lot more work in the sense of dodging those words and try to eliminate the stigmatizations as much as possible in the setting that I work in. Or otherwise, I may just easily lose a client at the spot, which I can't say that it hasn't happened before. So a lot of times, some nuances like this may tie into the the structure of stigmatization is towards the mental health field.
Well, that's really interesting, and I didn't realize that it's kind of the same characters. And so when we use this language, if it's directly translated, it's going to be interpreted differently. And so as you mentioned, you have to make cultural adaptations when you're discussing issues related to mental health, so that you're not using the same language, so that person doesn't feel like, oh, this doesn't apply to me, I'm not that. Um, and that it sometimes is helpful. Sometimes even then, it still can be challenging. Even when you try to use different language, just the idea of kind of having this or that issue is still kind of difficult to talk about.
Going off of the stigmatization with mental health, in my research for the Latinx community, I found that women are more likely to seek out mental health help than men, and it goes back to the concept of machismo. So machismo is a concept where the men are viewed as the head of the household, the strong ones, the ones that should take care and provide for their family. So a lot of times men from Latinx communities don't seek out mental health help because they don't want to be viewed as weak. They don't want to be viewed as they can't take care of their family. They don't want to have that negative association with admitting they need help in the moment. And it all goes back to the concept of machismo, which is still very present in a lot of family households today from Latinx populations.
And I imagine that given that so many of our mental health providers are women, that's kind of this additional barrier that, okay, well, you're asking this man who sees himself as strong and as the head of the family to go see a woman for therapy. I can see how that would be an additional kind of consideration too. And I know that there may be similar thoughts in the Black population as well, this sense of I'm a man and I don't need this extra help. And I know there's some groups that aim to change that, where there's kind of like Black men helping each other. I'm not sure if there might be similar things going on in the Latinx community where it's kind of like men helping each other to learn about mental health, to try to break those barriers, but it's so difficult. Yeah.
I mean, I feel like the whole emotionality in men is a worldwide issue that a lot of different cultures I've seen so far has been kind of taking steps towards, getting men a little bit more emotionally aware and emotionally sensitive. It's definitely something that I've seen in the Jamaican community, even as a result of the experiences that those men have had from their fathers growing up as well, that they didn't want to continue on. So that's something that within this generation and within this day and time has been really amazing to see.
Yeah, definitely. Definitely. And just kind of thinking about how, as a head of the household, and for many cultures, that is, not trying to be stereotypical about gender roles, but for many cultures, men kind of have this position in their family. And when they are not getting the mental health treatment that they need, sometimes we end up with other kinds of issues, affecting the family, alcoholism, substance use, this sort of thing. And so then that kind of trickles down to the next generation in terms of their mental health, and the kind of parenting they receive. So it's kind of like this ripple effect that can happen in families when our people are not accessing mental health services, or it's not presented in a way that feels accessible to them. Yeah. Wow. So I guess going along the lines of kind of psychological barriers, cultural barriers, what are some of the factors that might influence someone's kind of decision to access mental health services? Is there anything that has been effective for helping, people of varying backgrounds access mental health services? I know we kind of mentioned sometimes changing the language. Anything else we can think of?
I mean, one of the biggest things that I think about is meeting the clients where they're at. Like, that's one of the biggest things when it comes to psychology and even social work. And when that comes to mind, again, I think about the children that are coming and getting acclimated to the United States, and the fact that there aren't resources within those schools to help facilitate that level of acclimation. Mm-hmm. I feel like that would be a really good resource for us as mental health professionals to take advantage of, because not only do we have the ability to intervene with children that are now coming into the school community, but now we have the opportunity to reach out to those families to make sure that they have all of the resources that they need. So while they might not realize what's out there, or they might not appreciate the benefit of mental health, I know for myself that when I was growing up in the 4th grade in the middle of Connecticut, if somebody was there to tell my mom, hey, this is something that we can actually do that can benefit your child, my mom would not refuse that. She would let me go ahead and do that. And that would have been to the ultimate benefit of me growing up, instead of feeling so isolated, being thrown into a completely and totally white school where I was probably one of 2 Black children that are there. And not only that, I'm the only West Indian. You see what I mean? So I get thrown into an environment where I am completely and totally alone. And there's no one there to kind of facilitate, anybody understanding where I come from, or anybody teaching me how to operate within this new environment, and I think about a lot of other children that migrate here that has to go through that process, mm-hmm. and how that can end up leading to a lot of self-isolation, a lot of shame within your culture, a lot of substance abuse, a lot of violence, a lot of self-hate. and then that just keeps perpetuating on through the next few generations because we haven't figured out just a small way to kind of jump in there and see exactly where we can go.
Mhm.
I wish to echo what Jodianne has shared, since I do share a pretty much similar experience growing up as a 1.5 generation of immigrant from China. And I don't think there is any possibility of overly emphasizing the need to do more psychoeducation, not just on the child, but on the family, on the adult, just in general, in the sense that, well, sometimes we don't know, since people are coming from completely different cultures, completely different ways of using different utilities in life, and more than any different literature level, let's say per se, that can be hugely relevant. And a lot of times, if I were to share my personal experience growing up in China, people don't disclose that they have mental health issues because you will either get kicked out from the school due to their fear of having a suicidal case in school, which, like it or not, has happened before, unfortunately, or they will be prevented from attending certain type of jobs because people think that they're crazy and people are trying to avoid them. So in order to break a barrier like that, the whole systematic recognition of this country and this system and this type of services we offered can be hugely relevant. And I guess another thing I really wish to echo on is to have folks like us, who actually come from that part of community, who actually can speak to folks from that community from, I guess I will hope, a more personal ways, to let them know that this is not to harm them. This is not to try to, like to have them to disclose information that we will be using against them one day. This is not anything like that, and we're just here to help.
Mhm. That totally makes sense. And it makes me think of a couple of things. One is going back to something Jodianne mentioned. School-based mental health services is something that I think is really, really helpful for working with immigrant families. I used to work in a school-based mental health clinic, and it was interesting how it was one of the ways to be able to reach parents as well. So we would work with kids that were in school. They had to go to school. Schools, they can be enrolled in school whether or not they're documented. And so they're in school, and they can receive, and depending on the setup of the clinic, sometimes they can receive services regardless of their ability to pay in some situations. And in those situations, it makes it easier to reach families because, and then if we have a clinician who is of that culture, who speaks the language, that is key. Going back to what Tina mentioned, representation matters. It also leads me into this kind of discussion of the concept of mental health and how it evolved in the United States and I'm sure in Canada as well. But and who who are the ones who developed psychological theories, and who are these psychological theories for? And what was considered pathology, what's considered normal, what's considered abnormal, who are the ones that decided this? And there is definitely, a pattern in what these folks, their backgrounds are. And I wanted, maybe if you guys have thought about that or want to talk about that a little bit.
I mean, it's pretty obvious that a lot of the original theorists did not look anything like me or had my gender. So we know that there isn't a lot of multicultural representation when it comes to the original theories of psychology. But I feel like one of the beneficial things about diversifying the psychological field is the fact that we can now utilize these theories. And for me personally, I gear a lot of the things that I learn in school towards the Jamaican community, towards the Caribbean community, because I know that the way that we're taught it in schools, it doesn't work for Jamaicans. So for me, I have to think about what I see on a day-to-day basis when I am at home in Jamaica, and what I feel would be absolutely and totally beneficial to that community, because I'm the only one in my mind and in this school and in this sphere that can actually represent that particular aspect of the Jamaican culture. And the more we have diversity within the field, the more we're going to be able to adapt a lot of the interventions that we have to very specific cultures. And once you actually realize that when you adapt it for one, you adapt it for all of them, it's so much more beneficial. A lot of the things that they talk about when it comes to bringing recognition to the Asian mental health community is the same thing for Latino mental health, and it goes right back to Jamaican mental health. Every other culture, aside from the American European concept of psychology, like is practically the same. And once you realize that you only need to tweak it once for you to be able to utilize it for many different cultures, it's going to be that much more beneficial. We just have to see it as something that we're willing to invest ourselves into.
I agree.
I think one thing to go off of Jody-Ann's point is, when I was doing my research, came up multiple times that there is not research on minorities. There's not research on people of color, people of the LGBTQIA population. So how are we supposed to, like Jody-Ann says, adapt something when we don't have no one's doing the research on these populations, which is so important because they are different. They do have different considerations. Like, it just doesn't make sense. And I think that's something that needs to change within the field, to have more diversity, to be more inclusive of all the populations that do need the mental health help.
I agree with that as well. I think a lot of times when we see studies, I go directly to the methods section and see who is the participant section, who's enrolled in this study. What was the demographic breakdown of who was enrolled? And along with that, I think the burden is on researchers to figure out how to encourage people of varying backgrounds to be involved in research as well. So they're going to have to figure that out, how to increase engagement, but also to kind of make that a priority. So I think that's definitely something that's important. I'm glad you mentioned that, Jackie. It makes me think back to some of the historical kind of psychologists of varying backgrounds that have kind of break barriers in some ways, even like with IQ testing, how that was normed, and just kind of like realizing how culturally sensitive some of this kind of testing is that we use to determine children and adults. Their intellectual capacities are sometimes very culturally based. And so it's so lovely to be able to see, folks like you in graduate studies learning how to do testing, learning how to do these things, because I think this is how things will change. This is how you'll be able to pick up, wait a second, the person I'm working with, it's not that they don't know the answer to this question in terms of their intellect. It's because it's not culturally relevant to them, or it's a concept that doesn't make sense for them culturally. So I need to adapt my results of this to kind of match who they are. You'll be able to do that with a bit more finesse, compared to someone that may have less familiarity with the cultural differences. So I think research and testing and this sort of thing is going to really depend on a person's knowledge of the culture of the person they're working with.
I wish to add,
Go ahead, Tina.
I wish to add just like another factor as like clinicians specifically, if possible, that is the flexibility. Again, we're humans. I mean, I feel like I may understand something about my own culture, for example, but I wouldn't understand how everyone has been through. I wouldn't understand how other folks coming into this country in their 30s, 40s, 50s will have experienced versus my own experience. So a lot of times it's just to be humble and to be curious at the same time, to ask them, what does it feel like? And a lot of times, what I have experienced working with folks as a clinician is that I will have this sense of insecurity, feeling like, oh my gosh, I'm asking like so stupid questions to them. Like it's so obvious because it's kind of similar to what they have been talking about in terms of their symptoms. Well, you never know. Sometimes they will give completely different answers or something unexpected. And from their narratives, we can learn so much more about their family dynamics, their cultures, their backgrounds, and some really specific struggles that might only be applicable from their culture. So I guess just to take a step back, to not feel like we're like the professionals, can sometimes be a lot more helpful and reassuring to the clients that we work with.
Oh, yeah.
And I honestly have to say that one of the beneficial things about being here at William James specifically, this is my first full year in the clinical program, but I love the fact that even within my first year, I'm learning so many different concepts, and I'm learning from individuals that are in, like higher grades than I am. And it's so empowering and humbling within the same way, because you realize that as a clinician, like Tina said, you don't always have the answers, and one of the things about the Global Mental Health Academy is the fact that it doesn't just only teach me about how to work with African Caribbean individuals, but it's also making me a lot more mindful about how to work with the Asian population, how to work with the Latinx population, and how to utilize the way that I've developed my cultural identity, and to allow that individual that I'm working with to understand the same exact thing. And not because we don't have the same exact cultural identity doesn't necessarily mean that there isn't a way to get to a common understanding about how important that is to you, and that has been one of the most humbling experience I think that I have ever had, knowing that I have this huge amount of power in my hands. And we're so afraid to use it within our first year that sometimes you think that you're never going to get there. But even within this first year, I feel that all of the things that I have learned so far is exactly what's going to make me a good clinician once I get out there on my own. And that's the one thing that I can be so thankful for, because I know that a lot of multicultural individuals that has gone through the same experiences that Tina and I have acculturating to the United States are going to have a little bit more understanding clinicians, and that's all that you can really ask for.
Yeah. No, I'm glad you mentioned that, because sometimes this issue about kind of the balance between importance of representation, but also the importance of clinicians being culturally able to work with kind of multiple people, because you're not going to always have clients that share your same background. And even when they do share your same background, that doesn't mean you know everything about them. And so this ability to learn how to be effective as a clinician with multiple people, that's going to be relevant to everybody, regardless of their race, in terms of the person who's a psychologist is doing the practice. So I'm glad that you mentioned that we do have to step back and be humble, and kind of learn the things we need to learn, do the work that we need to do, and know how to approach people, from various angles. Oh, I think this has been kind of a great discussion so far. I mean, I know we kind of spoke a little bit about some of the kind of psychological and cultural barriers And then I think at the beginning, we kind of touched a little bit upon some of the practical barriers, and I wanted to return to that because there are some practical barriers as well. Sometimes I would work with kids, and their parents would be glad to come in and meet with me and talk with me. And whenever they have time, they do. But other barriers. They're working. They might not have transportation. These sorts of things. So let's talk about some of the other practical barriers. What about I guess maybe I'll ask you, what do you think about in terms of other practical barriers that might affect people in immigrant populations in the US?
I mean, let's not take away the fact that for children, sometimes the parents can be the barrier in getting access to mental health care. Wink, wink. I'm just going to leave that there. But also, you have to think about, the fear of deportation. Like you were talking about the job discrimination. You don't want your job to have to let you go because you're taking so much time to either take your child to the doctor or to take yourself to get mental health services. There's also the concept of, especially in Jamaica, the weakness of the character. They'll say that somebody who has mental health issues is, a madman. And they'll talk about how they're sitting there smoking weed and all of that stuff, not realizing that these individuals are smoking or doing all of these things to try and take care of the situation themselves. And the interventions that they're using isn't necessarily the problem. The mental health issues that they're struggling with is the problem. So when you consider that person to be weak of character because they're not strong enough to hold on to this pain, and they're outwardly expressing that they're in pain, you see exactly how someone can internalize that and how that mental health issue can get even further. You also have to think about the simple fact that there is a lot of times when insurances do not cover access to mental health care, or you don't have a job, or you're not qualified for a job that has mental health care insurance.
Right. So that's a big one, right? How can you access services if you don't have the ability to pay for services, the insurance coverage, or a job that would provide you with benefits in that way? Or you don't qualify, or maybe the insurance you have is very minimal because it's kind of that basic state insurance for people who don't have insurance. I forget what it's called now, but there's that basic insurance, but it doesn't cover all that much. And so it's kind of just enough to say there's insurance provided, but not enough to actually provide very many services, particularly mental health services. So I guess maybe
call it specialized mental health services
or specialized mental health services. So it's kind of like they're being kind of underinsured sometimes. So that could definitely be a barrier as well.
I wish to add, adding on to this whole insurance it could be like a back and forth struggle really in terms of this field. And I'm actually surprised in a nice way that we haven't talked about the language, the accessibility to one's language and the language barrier that it presents. So it reminds me of an experience I have had as a first year clinician in South Coast Community Mental Health, which is a mental health center that's primarily serving folks of Asian descent and folks who will need additional language support. So in the midst of COVID, we were having 6 months plus of waitlist, which is definitely not a surprise to many of you all working the field out there. And due to the fact that there are just no other Mandarin-speaking clinicians that are available to take patients out there, I basically had to sat with this poor lady who has been traumatized due to a fall at another location that goes under the same name of South Cove she was so much in distress, and she was hoping for an answer, for some type of resolution to the conflict that she has been having with the same clinic. So it was, I guess I would say, a really weird multi-relationship out there for me. But more than that, I just feel tremendously sorry for this lady, not only because of what she has experienced, but because of the fact that our clinic, despite how much they have been mistreating her in her sense, we are the only ones that she could seek out for help because we speak the language and we accept the insurance. Since she did come from a low income situation, we are one of the only ones out there who could listen to her, even though there is the conflict in the interest. That will be her only choice, her only options in terms of overcoming her fear of going to any clinic from now on. And just seeing how this type of disparities can play in everywhere. And by far, for this community, we are gifted because we do have a clinic that serves folks who only speak Mandarin or Cantonese or Taiwanese. But when I was thinking about other communities and other quote unquote small languages, and to see how folks living in those type of situations will have to face living here without the mental health care that they need, the disparities can be fairly relevant.
Absolutely. Language is such a big part of access to both mental health services and medical services. Mental health, even it's exacerbated because we have all these concepts and theories and ways that we say things, but medical also, because sometimes even explaining what's going wrong, where is the pain, what do I need, what are the symptoms, I think sometimes people underestimate if you're in a country, a foreign country. I don't know if you guys have ever had that experience of being in a foreign country where you didn't speak the language and you suddenly heard somebody speaking your language. And it's just like, oh my gosh. It's like this feeling of like, there's somebody else here that I can understand them. It's like an emotional kind of experience. And so I imagine that it's probably that same experience for someone moving to the US and then getting a clinician that speaks their language. There's a feeling of belonging. There's a feeling of understanding. So that would be the ideal. And then the second would be to have that language line. The language line can be very helpful, but what people sometimes don't realize is that you cover less in the appointments because appointments are scheduled for the same amount of time, but everything you say has to be said twice. So there is a bit of a barrier with the timings. You have to kind of try to cover everything, even though every sentence is said twice. And even sometimes there's a pause and like a cultural interpretation and a reinterpretation and still miscommunications that can happen with language lines. Sometimes even not understanding, for example, that two different tribes don't like one another and the interpreter belongs to that other tribe. And this person doesn't want to open up because they can hear the accent of the interpreter and they don't really trust them. And so just little things like that can happen with language. It's a huge, huge thing. I'm glad that you brought that up.
Going off the language piece, I work part-time at an inpatient facility, and we have to also consider the fact that basic human rights are broken all the time. They say they're guaranteed a translator and they have the right to a translator, but I can count on both my hands how many times a translator has been provided for someone who doesn't speak English in the facility. And then that just like adds to their isolation. They don't understand what medication they're taking. They don't understand their treatment plan. So just going off of that, like you said, language is such a huge, huge component. And then another thing I wanted to mention too is I think it's very important to have clinicians that, are of different cultures and that can relate and understand these people who have these needs. But at the same time, the system to become a clinician is broken. I learned that to take the test to become a psychologist, it's around $700. The study materials a lot of money too. And then there's no scholarships for these things. So how are people who, may struggle financially able to take the test and pass to become certified and licensed? Because it's just another barrier they have to face within the system. It's broken.
Yeah. Yeah, that's
If
absolutely right.
I can add to that one, I mean, like there's that there is one of the issues with having more of a diverse community coming into this field, because we say that we want diversity, but at the same time, there aren't enough resources to actually accommodate how much need someone from a diverse population might actually require to go through grad school to, possibly get into the field. Also going back to the language piece is that these issues, the lack of interpreters and certain things like that, is also one of the reasons why immigrant children are also at risk, because most of the times they have to take up the mantle of being the interpreters, and they get pushed into a position within the family that is kind of skewed based on cultural values. Now they know more information than they're supposed to. Also, a lot of the times with interpreters don't necessarily always say back the same exact thing that a person is saying. I also work with the deaf and the blind community. So you see this a lot of times as well, when deaf interpreters are interpreting things back to the doctors, and they're paraphrasing some of the things that the individual is saying. And a lot of the time the message gets missed within, those kinds of situations. And it's absolutely and totally amazing when you consider people who are immigrants, who are also disabled, and how we're talking about all of these disparities that immigrants are facing. But it gets even more compounded when you think about the fact that when you add disabilities, when you add sexual orientation, when you add certain other things, the higher societal view of them gets skewed so much more that they're not getting services. Mm-hmm. They're not even getting access to even getting through the door to see someone for their mental health issues or whatever it is that they need to address. And this is also a problem that we need to start researching, and we need to start putting out there so that we're more aware of exactly how individuals with multiple minority identities actually do, survive within our country.
Yeah. I mean, that's exactly right. I mean, what do you do if there's kind of multiple things all at one time? I mean, it's enough even if somebody moves to the country, and even if they have all the resources and everything, they still have a lot of these barriers. And if you add one to another, if all these intersections. And then the other thing, that we haven't mentioned is sometimes somebody who's moved to the country for the first time, depending on the circumstances under which they moved here or the resources, they may have housing issues, or they may, if their finances are a certain way, then they may have difficulty having access to food. And so have you guys thought a little bit about how things like housing and access to food might affect mental health services?
So one of the things that I was looking at is a lot of the times highly immigrant population or highly populated areas with immigrants are usually food deserts. They're very far from grocery stores. There's a lot of fast food that's around. You have corner stores that are being dubbed as grocery stores, and that doesn't even have fresh fruits or vegetables. You also have the fact that a lot of times immigrants are living in urban areas, which are typically sometimes could be higher on crime. So that's also one stigma that prevents them from getting healthcare, and something that also helps in adding more mental health issues. Because when you think about high crime and somebody's being in that environment on a constant basis, that also contributes to a lot of PTSD and a lot of issues like that moving further on in life. So And then you think about the education factor. How much education did someone have before they migrated to this country? Does their education actually translate to the US? My mom was a police officer in Jamaica, and when she came up here, they told her that she would have to go through the academy all over again. So she decided to be a CNA, right? So there are so many different things that contribute to access to housing. You know, you also have to think about the fact that if you're a little bit too brown, what areas, especially in Boston, you're going to be allowed to go and live in, you know, and that also contributes, because now you're thinking about the areas that individuals, the Black communities that individuals are living in, and the healthcare centers that are around there. While they do have mental health care, it's usually so overcrowded and understaffed that individuals that's in that area can't even get an appointment, even if it's right down the street, you know, so.
Yeah.
Another thing regarding housing too is specifically for undocumented immigrants, landlords often exploit them because they have no legal leverage against them. So they can raise the rent, they can evict them at no notice, they can do any of these things because they have no leverage to fight back, which is truly terrible. I remember when I worked for youth villages doing family work in people's homes, one of my clients' moms received an eviction notice, but she didn't speak or read English. So the eviction notice went by and the days passed. And then they're being almost kicked out on the street because they said, well, we sent the letter, and they did send it, but it wasn't in their language. So there wasn't much they could do. So she was at a loss. So it's just stuff like that happens that you don't really think about, that really affects these populations.
So it sounds like there's a lot of trauma involved with, you know, the threat of suddenly losing your housing, or just not being able to be sure about or not feeling like you're safe where you live. I imagine sometimes, depending on, again, where the person is coming from, they may have actually, where, you know, the situation that they had been living in their own country would have been different from this kind of very urban kind of setup in wherever they're living now. And that can feel like a shock to them, especially, you know, think about Jamaicans coming, you know, if they go to an urban set where they have no access to fresh food, it's such a difference to not have access to the foods that you're used to. But I think it'll be the same for other populations as well. I mean, from, you know, Latinx countries, you know, this kind of thinking, don't have access to the things that I normally would have. And so it's like there's these trade-offs where it's like you come to the US for certain reasons, but then there's some things you lose as well, or some things that are kind of rocky. So any last thoughts as we kind of start to wrap up a little bit on this topic of mental health services for immigrant populations in the US? Anything that you wanted to share that I didn't ask about, or anything, other kind of comments? I think it was a really great discussion. I thank you all so much for joining me today to represent the kind of the perspective of multiple cultures and backgrounds. I think the work that you guys are doing is amazing. I wish that there was, you know, more financial support so we could have more diverse grad students that often do have to think about a lot of different things when they go to grad school. As you guys mentioned, you know, there's a cost associated with grad school, and that can be a barrier for a lot of people. I know in medical training, don't even talk about it. That's a huge barrier for trying to get diversity into medical training. Years and years of finances and loans, and not everybody qualifies for loans and all that sort of thing. So hopefully over time that will improve, and we'll have more people like you guys kind of leading in this area. So, and I want to thank you, all of those of you out there that are listening to this podcast. Thank you so much for listening. Thank you for joining me today. I hope you have a wonderful week, and I'll join you again next week. So take